Hello, my name is Jamie O'Byrne. Thank you for viewing this talk entitled Validation of an Algorithm to Identify Diabetic and Pre-Diabetic Patients from Electronic Medical Record Information. I am a statistical programmer analyst with over 10 years experience at a large, well-known Midwest healthcare organization. This talk is based on work done to validate a phenotype using American Diabetes Association criteria to identify diabetic and pre-diabetic patients. I have no conflicts of interest to disclose. Diabetes is a disease characterized by high blood sugar. Sufferers often develop high blood pressure and high cholesterol. The disease can lead to heart disease, stroke, blindness, kidney failure, lower extremity amputations, and ultimately death. Risk factors for diabetes include smoking, obesity, physical inactivity, high blood pressure, high cholesterol, and high blood glucose. Approximately 12.2% of the 2015 U.S. population, or 30.2 million people, suffered from diabetes, which is the seventh leading cause of death in the U.S. Rates of diabetes differ by age, sex, race, ethnicity, socioeconomic factors, and geographic location. Diabetes has been a national health focus for many years. However, awareness of prediabetes as a distinct focus is more recent. The first national campaign was launched only in 2016, jointly by the Centers for Disease Control, the American Diabetes Association, and the American Medical Association. Prediabetes affects an estimated 84.1 million people, or 33.9% of the U.S. population, and many of these people are unaware that they have this condition. The aim of this project was to validate a computer-based algorithm that uses clinical and administrative indicators of diabetes and prediabetes to automatically identify these disease cohorts. This was done by comparing the results of the algorithm with a gold standard on a sample of patients' data. This comparison will give a measure of confidence in the use of this algorithm in a larger dataset. The Rochester Epidemiology Project is a large, locally available repository of healthcare information for inhabitants in the Minnesota and Wisconsin regions. Data from this repository was extracted from the timeframe between 1999 and 2014. Patients that did not consent to research authorization according to Minnesota statutes were excluded. Patients with a strong indication that part or all of their healthcare took place elsewhere than the primary healthcare site were also excluded. Patients with age at first record in the repository of less than 18 were also excluded, consistent with national metrics. Women with indications of pregnancy were excluded to avoid false positives related to gestational diabetes. An algorithm, implemented in SAS, used clinical measures defined by the ADA to identify diabetic and pre-diabetic patients. Phenotype categories identified by the algorithm are mutually exclusive and exhaustive. Presence of two or more measures from the top box indicate a diabetic patient. One measure from the top box and/or one or more measures from the second box indicate a pre-diabetic patient. Measures in the third box indicate a normoglycemic patient. Due to the presence of testing for diabetic indicators with no positive results, normoglycemics are assumed healthy but at increased risk. Lack of any testing for diabetic indicators indicates a healthy patient. The results of the algorithm were compared to a gold standard. This gold standard consisted of two physician reviewers with extensive experience treating diabetic patients. Assessments of the sample of patients were made independently by each reviewer. Each reviewer classified each patient into one of the four phenotypic categories using their clinical experience to make the determination. The results from each reviewer were compared and inconsistencies were jointly reassessed by the reviewers and reconciled. The physician reviewers were blinded to the results from the algorithm to prevent biasing the results of the gold standard review. Cohen's kappa is a well-accepted measure of agreement between two raters for assessments on an ordinal scale, as in this case. Kappa makes the distinction between agreement by chance and agreement beyond what is expected by chance. Weighted kappa incorporates information about the distance between categories when assessments disagree between raters. Disagreement in neighboring categories is less serious than categories further away. Intraclass correlation is a comparison between the variability of ratings made on a specific subject compared to the overall variability in the data. McNemar's test for marginal homogeneity assesses the null hypothesis that the row and column distributions are similar. Polychoric correlation, also known as latent continuous correlation, is useful when an ordinal categorical variable may represent an underlying continuous trait. Clearly, here it is easy to imagine patients completely free of diabetic disease as well as those with complex diabetic disease. These represent endpoints on a continuum of illness represented here by a 4-level categorical variable. Linear bilinear association models are a subclass of log linear models, which are useful when variables representing cause and effect are not clearly identifiable. Linear bilinear association models are useful to model the association between ordinal categorical variables by assuming that agreement will be strongest at the extremes of the ordered categories. The validation work required chart review by the gold standard reviewers. Chart review is costly and time-consuming. Therefore, we wanted to limit the cost of the chart review portion of the validation while maintaining high power to detect statistical significance in our measures of association. We opted to select a random sample of patients from the rep repository. Using PAS15 power and sample size software and estimates for proportions of each phenotypic group obtained from national data, we calculated a reasonable size necessary to provide 80% power with alpha equals 0.05 and the proportions shown below for the kappa statistic of inter-rater reliability. Ultimately, 159 subjects were randomly selected for chart review. Subjects in the sample were primarily male, average age 39 years, white, had high proportion of postgraduate schooling, average height of 171.5 centimeters, average weight of 80 kilograms, and average BMI of 27.3, which is considered overweight according to the World Health Organization. Other than mortality, no significant differences were found between the demographic makeup of the sample and the rep repository as a whole. This may indicate that our sample was unexpectedly healthier than patients in the rep repository typically are and may represent a shortcoming in our study. Raw agreement between the algorithm and the gold standard review appears to be strong, with similar proportions of all groups being selected by both the algorithm and the gold standard reviewers. With kappa 0.82, there is a strong indication of agreement in the classification of these patients into the 4-category phenotype. The quadratic weighted kappa, more appropriate when analyzing ordinal data, showed similar but stronger agreement at 0.86. For both the unweighted and weighted kappa, even the lower bounds of the confidence limits showed substantial agreement, and the p-values for the tests comparing their results to the null hypothesis that kappa equals 0 were highly significant. This indicates strong evidence that these kappa scores are significantly higher than agreement by chance. Intraclass correlation is high at 0.86, showing that most of the variability in the data is the result of variability between categories of the phenotype and not variability that results from the 2 classification methods performed on individual patients. Here there is low disagreement. P-values for all McNemar's tests of marginal homogeneity are non-significant. We have no strong evidence to reject the null hypothesis of row and column distribution similarity. Polychoric correlation is high at 0.92 with low standard error. From this we can infer the existence of some latent continuous characteristic that underlies the categorical classification used in this study, causing strong agreement between raters. The likelihood ratio test was used to assess the linear bilinear association model and showed strong indication of a linear relationship between the algorithmic phenotype classification and the gold standard result. The beta estimate for the linear relationship between the algorithm's phenotype and the gold standard phenotype was 1.06, which gives an estimated odds ratio for a unit increase in row and column score of 2.88. As the category of one phenotype increases, there is a 288% increase in the odds that the category of the other will increase also. This work deployed the American Diabetes Association guidelines for identification of diabetic and pre-diabetic patients in the form of an automated algorithm. At-risk normoglycemic patients are identified incidentally. In the presence of an electronic medical record, this is a viable, inexpensive, and time-efficient way to identify large cohorts of patients on the diabetes disease continuum for medical research or intensive disease management efforts. Thank you.